Hi, everybody. Thanks for joining this Rare Disease Day discussion today. We'll be getting started in just a couple of moments. All right, so I think we can go ahead and get started. We do have one more panelist who will be joining in just a few minutes. But good morning, everybody, and thank you so much for joining this panel discussion today in honor of Rare Disease Day. We have a really exciting discussion planned for today, focusing on the theme of generating change through patient-centered care. I'm joined by 4 members of our editorial board and fellows, who will each be highlighting a rare disease today, including uveal melanoma, plasma cell leukemia, pancreatic neuroendocrine tumor, and myelodysplastic syndromes, and helping to raise awareness of these diseases. If anybody has any questions for the panelists, feel free to type them into the chat, and we'll have some time to answer them throughout the discussion at the end. So with that, I will turn it over to Dr. Hadfield to start off the introductions.
Thank you so much. It's very good to be here on such an important day. I'm Matt Hadfield. I'm a medical oncologist at Brown University in the Legorreta Cancer Center in Providence, Rhode Island. I focus on early phase clinical trial development as well as cutaneous malignancies, but I treat uveal melanoma as well, which is my tie to rare diseases here, as well as Merkel cell carcinoma. So very, very important diseases to keep in mind and that we need to give a lot of attention to. Very, very excited for this conversation. I can turn it over to Erica Fortune, maybe to introduce yourself.
Thank you so much. I'm Erica Fortune, and I'm the Vice President of Research at Cancer Support Community. If you have not heard of us, I'm sad to hear that. We do a lot of amazing work. We're a global nonprofit working to support all cancer patients, survivors, caregivers. So we are a pan-cancer organization representing any point in the cancer experience and timeline. And today I'll be sharing about our myelodysplastic syndrome, rare cancer, and what we do in that patient space. So just so happy to be here with you today. And I'll turn it over to Arthur.
Hi, everyone. I'm Arthur. I'm one of the first-year fellows at Zucker School of Medicine out on Long Island. I'll be talking about pancreatic neuroendocrine tumors. I think it's a very interesting, before I actually joined fellowship, I've never heard of this disease. And it's a very interesting spectrum of cancer that I'm very excited to share with you guys about and hear what your perspectives and how your experiences have been as well. Yeah, I'm excited to be here today.
No, great. And I think our third panelist is unfortunately stuck in traffic, from what I heard. So maybe we can get the conversation started. I can start by speaking a little bit about uveal melanoma, and I think it would be, while we're talking about quite a wide array of diseases here, myelodysplastic syndrome to pancreatic neuroendocrine tumors and uveal melanoma, they do share some very common characteristics in that they're very rare and uncommon types of malignancies. And there's quite a bit of hurdles with these types of diseases. For instance, accruing to clinical trials is very challenging because their patients are so uncommon and oftentimes away from centers that are doing these types of trials that it can be very very difficult to recruit them. Additionally, and this is where advocacy groups become so important, is that the way to find specialists or be treated by people who have extensive experience in these areas often is through word of mouth, through advocacy networks and things of that nature. So again, I'll start with talking about uveal melanoma. It's a very, very uncommon type of melanoma that is only occurs in about 4.1 million people a year in the United States. It's much more common in people, patients of European descent, and extremely rare and uncommon in other ethnicities. And up until the last few years, we've had very few treatments that were effective for uveal melanoma, and that sort of changed about 2 or 3 years ago. Prior to that, we used chemotherapy with very little success. We also used immune checkpoint inhibitors with also very limited success. And then the development of a drug, tebentafusp, which is one of the first T-cell engaging types of drugs, which is a drug that hones T cells to the tumor. Received FDA approval for uveal melanoma, and has opened up, now a couple other FDA approved medications in this space. So there is progress, which is very, very exciting, but again, very, very challenging to conduct trials in this space. Very, very challenging to develop new therapeutics in this space. So maybe, I don't know, Erica, maybe you could talk a little bit about your organization and myelodysplastic syndrome and what you're doing there.
Yeah, absolutely. And again, CSC is a pan-cancer organization, but part of what we do is try to represent every single voice that we can represent in the cancer space, and that absolutely includes rare cancers. So we've been doing work in the rare cancer space for more than a decade at CSC, and today I will be speaking specifically about myelodysplastic syndromes, or MDS, which again, many people have not heard about. It is not a very common set of cancers. It's a rare blood cancer disorder, and it affects roughly 10 to 15,000 new cases each year, right? So this is not something that we see as being very common in the United States. And it's a set of rare cancers that affect your bone marrow specifically and will ultimately affect your blood counts, right? So usually it's going to affect your red blood cells, but it absolutely can also affect your white blood cells and also your platelets. And a lot of the difficulty in MDS starts just from the very beginning and understanding that you have MDS and getting it diagnosed. And then part of that diagnosis is going to include multiple different types of risk factors that the patients need to be aware of, right? So I think, again, the challenges with any rare cancer is understanding what you're going through and being with a provider who really understands the disorder itself. So just to give you a little bit more background on MDS staging and diagnosing, there's three main things that you want to consider when you're being diagnosed with MDS, right? So understanding if it's a primary or secondary diagnosis. So 80% of MDS cases are going to be primary. So this means that it's not going to necessarily be related to anything that you're aware of. It's a spontaneous emergence of MDS. The other 20% are going to be a result of other types of cancer treatments that you've had in the past. So the first thing to be aware of is if it's primary or secondary. And then you also need to be aware of your World Health Organization subtype, right? So there are 6 different types of MDS, and that will speak to the exact type of cancer that you have, which will then inform your treatment. And then lastly, you need to understand your International Prognostic Scoring System risk score, and that will also speak to your specific risk, and that might guide your treatment as well. So already, right, everything you've just heard, that's a lot. That's a lot of information for a patient to take in, to understand, to realize what their actual diagnosis is, right? To just understand what the diagnosis is, and then understand how that diagnosis will then inform their treatment path. And so for treatments, like many other cancers, there's not just one thing. There's not just one treatment that will work for everyone. And so it really is up to the patient and having conversations with their provider to understand how their specific diagnosis and risk would inform their treatment pathway. And in doing so, making sure to ask those very important questions. What are the goals of this treatment for me, right? Because the goals are not always the same person to person. What are the goals of this treatment for me? And what are some of the side effects that I can expect from these types of treatments? And those are the types of conversations that we're hoping patients are having with their providers, and then will ultimately determine perhaps what treatment pathway they go on. That said, some of their treatments will be determined by their risk, right? So the higher risk you are, the more intensive those treatments will be. And you might see things like precision medicine and targeted therapy that's becoming more popular across all cancer types, but is also becoming more popular in MDS. And I can speak a little bit more to this later on about some clinical trials that exist in this space right now to expand treatment in MDS, but I want to make sure that I give Arthur a chance to give an intro into his rare cancer.
Yeah, absolutely. So we'll be talking about pancreatic neuroendocrine tumors. This, it's a type of pancreatic cancer, but this is the rarer form of pancreatic cancer. It's typically, when we hear pancreatic cancer, the ones that we're most likely talking about is pancreatic adeno, which behaves very differently from the neuroendocrine tumors. So neuroendocrine tumors, that's about 1 to 2% of pancreatic cancers. And it comes from the pancreatic islet cells. So those are the cells that actually produce hormones. So a lot of times, pancreatic neuroendocrine tumors will be, they're considered functional, meaning they're secreting hormones and causing symptoms. Sometimes they can be non-functional. They may not be producing any, they may be growing, but they're not really producing any hormones. It is rare. The incidence is about like 1 in 100,000 per year. And because it behaves so differently, the clinical spectrum, it can be very indolent, meaning like it's not really causing any issues. Patients may not even experience any symptoms, to more aggressive forms where it's really an aggressive, highly metastatic, quick-growing tumors. So because of that, the prognosis is so variable, and the way we treat is very variable depending on how the clinical behavior of this tumor is. Some of the treatments we do, we may use hormonal treatments or targeted treatments to chemotherapy if this is more of an aggressive tumor. And a lot of times it's really picked up like basically on scans. They were getting scans for other reasons, but we find something in the pancreas, and patients may not have any symptoms, so that's how they find out. Others, they may be misdiagnosed for a long time because some patients may come in with like chronic diarrhea, or like kind of like abdominal pain, diagnosed as peptic ulcer disease. For a while, symptoms do not improve. So it may take a while and cause delay in diagnosis until a definitive diagnosis is obtained. So it's a very interesting spectrum of disease, and I look forward to shedding some light on this disease.
Well, that's very, very. Both of you had such great things to talk about, and there's so many avenues we can go down. But before we do that, Dr. Thakur has joined us. Do you want to maybe introduce yourself and talk about which rare cancer you're speaking about today?
Sure. So, hi everyone. I'm so sorry I'm late. My name is Richa Thakur. I'm a third-year hem-onc fellow at Northwell, and I'm going to be talking about plasma cell leukemias. And what plasma cell leukemia is, it's on a spectrum of the plasma cell dyscrasias. So most people have heard of monoclonal gammopathies or multiple myeloma, which is basically where the plasma cells are located inside the bone marrow. And in these situations, either with a monoclonal gammopathy of like unknown significance like MGUS, they just have a slightly increased level, but they don't really cause havoc on the body. With myeloma, those plasma cells increase their levels of production of the protein and then attack different parts of the body. So like the bones, they decrease. Other side effects you have are like problems with your kidneys and then increased levels of calcium. When those plasma cells leave the bone marrow and they're circulating in your blood, that's what we call, at a certain level, that's what we call a plasma cell leukemia. And in this case, we often treat it as a combination of how you treat other leukemias with very aggressive cytotoxic chemotherapy, but also a combination of your anti-myeloma agents too. And what makes this a very challenging issue is that there's multiple subtypes of this, meaning there's plasma cell leukemias that are present de novo, like primary, versus patients had myeloma before and the cancer had progressed to the PCL. And what makes it very difficult is that just because the case is so rare, it's very hard to figure out the right combination and the right sequencing of drugs too. And unfortunately, like multiple other rare cancer types, it's not just the number of patients you have. There's other treatments that might overlap with it, but when you look at clinical trials, sometimes these are also counted as exclusion criteria for the clinical trials too.
No, absolutely. I think one thing that kind of stuck out to me about that all of us sort of touched on is that one of the big shifts in oncology, particularly in the last 10 years, has been towards targeted therapies as well as immunotherapies. And thankfully, we've started to almost in some ways redefine how we describe cancer based more on molecular makeup as opposed to the histological subtype. And that's generated avenues to include more patients in clinical trials more in a tissue agnostic way, as opposed to just thinking about it as which disease they have. I'd be curious if any of you could speak to how these specific cancers that you're speaking about have been transformed by that evolution in therapies. And I think we have a question too, maybe we can get to right after we do that.
And I can start and just speak a little bit to what I'm aware of that's happening currently in the space with MDS. I know that NCI has MyeloMatch, which is a group of clinical trials that's hoping to align people with either acute myeloid leukemia or MDS with the right treatments for them based on their markers in precision medicine. And that is an important fact. I think I failed to mention earlier is that when it comes to MDS, which is already a rare cancer, there's a lot of uncertainty related to that cancer. 1/3 of people with MDS will progress and develop AML, right? Acute myeloid leukemia at some point in their future. So that just adds to the critical need and the uncertainty that surrounds MDS as a rare cancer. But again, back to the point, there are a lot of developments happening in precision medicine in general. And my understanding is that MyeloMatch clinical trials is really working towards finding that matching of the right precision treatment for people with MDS or AML.
Arthur, how about you? Do you want to speak a little bit about how targeted therapy and
Yes.
different novel mechanisms, because neuroendocrine tumors
Right.
is another area in which there's been it's benefited from tissue agnostic type trials and newer therapies.
Yeah, so from my, a lot of the targeted treatments from my experience, there's a lot of like targeted against VEGF or mTOR, basically like targeting the cell proliferation. I think there's some ongoing trials looking at liquid biopsies, and then using like in terms of surveillance as well as like developing new targeted treatments. There's also like, I think for like more of like the progressive disease, there's like some trials looking at immunotherapies in that space. So definitely like a place where like there's more growing research. Yeah.
Great.
So with plasma cell leukemia, the targeted therapy is usually geared towards similar markers that are on the myeloma cells. So the ones that we use mostly are anti-CD38 monoclonal antibodies like daratumumab. Other like cellular therapies are more like anti-BCMA specific, but all of these regimens are really approved specifically for myeloma. And so when we create the dosing, the scale, everything, it's based off of a myeloma regimen. But when you're treating like primary cell leukemia, or sorry, plasma cell leukemia, whether it's primary or secondary, it depends on what the patients were exposed to before. You end up adding multiple agents as opposed to a triplet. Sometimes you have to give like combinations of 6 different chemotherapies. It's just, unfortunately, a lot of the data we have shows improvement in survival or improvement in response rates, but it doesn't really teach us how to optimize the sequencing of these things either. So even though we have these targeted therapies, knowing how to best deliver them in each of these settings is also really important to figure out too.
No, absolutely. And I mean, there's so many questions now too about access to things. Like I know in that space, similar to where we're moving in melanoma, T-cell engaging therapies require a lot of logistical support to give and monitor. So there's lots of developments, but there's also lots of questions. I did want to pause quickly. So the question that we received from someone was, what advice do you have for patients who are experiencing symptoms that they feel their provider is minimizing or ignoring? I can kind of start and then open it up to everyone else. I think you always have to feel comfortable with who's treating you, especially when it's a malignancy. So if you have, and I would say that oftentimes physicians and patients can be very personality dependent. What works for one patient just does not work for another patient, and sometimes you click with your doctor and sometimes you don't. But if you feel like there's anything that's not being addressed by a physician, it's no physician would or should ever be offended or put off if you want to get a second or a third or a fifth opinion for your cancer. In fact, we encourage that so that you feel comfortable with how you're being treated and how your symptoms are being managed. And I would also say this is where patient advocacy groups can be absolutely critical in opening up conversations with other patients, especially when you're in the rare cancer space. Other patients who are dealing with similar things, rare cancers tend to have like neuroendocrine tumors, uveal melanoma, myeloma, myelodysplastic syndrome. They have very similar symptoms. For instance, pancreatic neuroendocrine or uveal melanoma, there's issues with eyesight. There's issues with the side effects from the treatment. So connecting with that group of people can be just absolutely critical in figuring out if the person that you're seeing maybe isn't addressing things the way you would hope they would, and direct you in another direction. I'm not sure if anyone else has any other thoughts.
I feel like you gave me the plug for me, go to advocacy groups, which I love to hear. So first and foremost, always, if you feel like you're not being heard, seek that second opinion or that third opinion, whatever you need to get the answers that you need to get. And it is especially challenging in a rare cancer space, even at the start of diagnosis, right? So with something like MDS, as I mentioned earlier, even understanding that you have MDS because the initial symptoms may resemble something else, right? And so you're not really sure what's happening, and it takes a while to get to that diagnosis. But once you have it, or if you're experiencing other symptoms that you feel like your doctor is not hearing when you say them, in addition to getting multiple opinions, always advocacy. So at CSC, again, as a pan-cancer organization, we do what we can to align individuals with support and resources. And even if we personally can't provide it to you firsthand, we will help find the people that can. We will also help find people that are like you, that have similar cancers, who may have similar experiences. And once you hear about other people having the same experiences, it gives you more credence. It helps you understand, okay, this is real. I'm going to continue to pursue the answers to what's happening here. So again, just to reiterate, always multiple opinions and lean into advocacy when you can.
A couple things I would also want to add on top of symptoms too is I think it depends on what your concern specifically is with the symptom, because sometimes the symptoms manifest as like the cancer progressing. Other times it's a complication of the treatment too. And getting a second opinion from an oncologist will be really helpful to figure out the differences between this, or if there's other treatment options that might give you better care in this case. But the other part of this too is sometimes it's not a second opinion with another oncologist. Sometimes it's a different specialty too. Like, do you need to see palliative care? Do you want to see a physical therapist if it's a lot of pain? Do you have something that's completely not related to the cancer or the chemotherapy, and you might need to get another workup too? So I think making sure at least you follow up with not only a second opinion, but your primary care doctor, any other specialist is sometimes common sense. But like it's common sense after someone says it, not before. But the other part I would also add on top of this too is oftentimes it's very hard for physicians to figure out symptoms without having like a timeline of how it is. So even if you get a second opinion, I personally feel it's also helpful to follow back up with your primary oncologist and the person that did the second opinion if you don't get this, just so they can see how the symptoms evolved over time. And you might get a different opinion the second or third time you go back to the same person too.
Very well said.
Yeah, I agree with that too. Like, I think what everyone says for sure. And sometimes, I think having a different set of eyes, take a look at a problem, definitely really matters. Yeah, I remember when I was in residency, I think this patient basically kept coming to the hospital with hypoglycemia. And, I think easiest thing to really attribute it to was they were on they were on diabetic agents, so that's why they were getting hypoglycemic. But if something keeps happening repeatedly, I think then you have to think outside the box and try to figure out, this doesn't sound normal, something else seems to be the case. I think that's when he got admitted, and then we started working him up. Turns out he had an insulinoma. So sometimes, trying to get a thorough history and then trying to see what doesn't fit, I think really helps. and a thorough workup is recommended. So clearly, I think, really finding a provider, a physician who listens and try to work through a problem, I think would be the most something that I would really recommend.
Yeah, so many good points here, and I think that's another really critical thing to mention is that other specialties are critical, especially as we've entered the era of cancer therapy is getting so complicating. I mean, the world of immunotherapy toxicities, CAR T, targeted therapies, cancer vaccines, there's lots of side effects that we just haven't dealt with before. And colleagues like palliative medicine are absolutely critical in that. They can be wonderful support systems, and they can provide their extensive knowledge on managing symptoms, and oftentimes people have the wrong connotations about what seeing a palliative medicine physician is. They think that that's a transition to hospice, but it's oftentimes just an incredible team of people to have in your corner as well, including oncology pharmacists, nurses, nurse navigators. I mean, but yeah, I think to wrap that up, more people is often better, and second and third opinions are also welcome. Okay, so I think getting back to the initial conversation, although that was a great segue, that makes me kind of think of patient advocacy groups and how they can be so critical with this specifically. I think some of the things that we talked about before is applicable to any cancer patient, but specifically in this space when you're talking about rare cancers, I was fortunate to be invited to speak at a Cure in Sight, which is a uveal melanoma advocacy support group last October, and I was able to speak with patients who have uveal melanoma from around the country and the world, and I think there is such a profound benefit to having those types of groups available, and especially now when communicating is so easy compared to how it was 20 or 30 years ago. I'm really curious to see if anyone else has any experience with patient advocacy groups in these situations or in others, because I found them to be really, really beneficial to this patient population.
And I'm biased since I work at an advocacy organization. But to your point, we interact with patients, survivors, and caregivers on a daily basis in a number of different ways. And in the research department, which is again where I am located, we do multiple different types of research initiatives where we gather patient insights and voices. So one of those initiatives is our longstanding cancer experience registry, which is open to all cancer patients, survivors, and caregivers, regardless of diagnosis or time since diagnosis. And currently in our registry, we have around 150 individuals who have been diagnosed with MDS. And so in having that representation, we're able to better understand what their patient experiences are like and what some of the challenges are that they're having along that treatment experience and cancer experience. And I can tell you, right, in looking at some of that data recently, that we see these trends that you would expect based on MDS and the way that it affects your blood counts and your body, that people who have MDS in our cancer experience registry report that they have greater amounts of fatigue than any other people in our cancer experience registry, right? So compared to everyone else in our registry, people with MDS have higher fatigue, they have lower physical function, they have lower social function, right? So what we're speaking to here is a whole person model of care, right? That understanding that it's not just about one specific aspect of the cancer experience that a person is dealing with. They're dealing with multiple different things at once, including their physical health, their social health, their emotional health. And the only way that we can actually support the whole person is by understanding that, right? So as an advocacy organization, we love to provide that support. That's what we want to do. But we also like to gather those insights so we know exactly what support to provide. And I'll just say one other quick thing before turning it over to the other panelists, is that when we ask people with MDS, what are some of your primary areas of distress right now? It wouldn't be surprising, based on what I just said, that they're really worried about their overall level of functioning, right? What they're able to do, their fatigue levels, that's affecting people every single day. And then as you might imagine in any cancer, one of the biggest areas of concern is the cancer progressing or coming back and worry about the future. But think about what that means for people with MDS or any other rare cancer. That uncertainty, right, about what is going to happen next is elevated, even more so, right? So just understanding that uncertainty, recognizing it's real, and then helping people through that uncertainty, I think is a really important piece of what we do in an advocacy world.
So well said. Oh, go ahead, Arthur.
Oh, sorry. Yeah, so my experience in this, space has been quite limited, but I'm just curious to see in terms of like, how do we get patients plugged into advocacy groups or like support groups? How in your practice, how have you navigated that?
I would love to hear Erica's input on this because I'm sure she has a lot of great things to say.
How
from
do
my
you
own
define
perspective,
you guys? Yeah, usually.
like I said, I got involved in a specific advocacy group for uveal melanoma, and so thankful that I did. I think from my perspective, and Erica hopefully can elaborate a lot more than I can, but specialists are often encouraged to get involved in these groups and be resources for patients too. So I think it's just developing a community.
Absolutely. So I would say from our standpoint, we have multiple different ways that we reach the patient, survivor, and caregiver community. So it's not one set way, but we partner with health systems and organizations, with doctors to recommend and refer people to us. We also have 196 actual brick and mortar locations that provide free psychosocial care and support to people. So there is that sort of location awareness where we can direct people to our services. And we also work as often as we can with other advocacy organizations. So what I like to highlight is that we're just one, right? So there's always strength and partnership in numbers. So we refer to each other, right? Because we are pan-cancer. If we have patients, survivors, caregivers who are dealing with a specific diagnosis, we may say, hey, there's this other amazing advocacy organization. Let me direct you to them as well. So to your question, we get people from a variety of different ways, but we love to partner with doctors, with hospitals to refer people to our advocacy services.
Wonderful. That's so important. And I think not enough people know about these types of things. So it's great to have you speak to that. We did receive another question. When should palliative health be discussed with patients? I have pretty strong opinions about this. I think as early as possible. I don't think there's any harm in involving palliative care colleagues earlier than later. Oftentimes they could be super helpful with adjustment to diagnosis, with symptoms from treatment. It's just a great team of people to have involved and be part of your care. And I think, I certainly run into this all the time. I see patients on early phase clinical trials, so often patients who have exhausted all of their options and are now looking at like first in human studies. So we reflexively have people with palliative care or refer to palliative care when they come to see us as part of our normal process. But I think there's a real big stigma that it's associated with giving up and not pursuing any more treatment, and nothing could be further from the truth. It's that there's so much more than that's not really at all what they're doing. So I think as early as possible, but I'd love to hear everyone else's thoughts.
So as someone that's both an oncologist and a palliative care physician, I have a huge bias towards this, and my bias is
full disclosure.
diagnosis. It's never too early to bring up palliative care. But the thing is, it's also very tricky because when a patient's diagnosed, it's a lot of information at once. So like we can throw support groups, we can throw treatments, we can throw next line things at patients, but the problem is there's only so much you can retain after a 20-minute period. So for me, it's whatever you want to bring up with patients, whatever their most pressing issues are. It's better to trickle slow things over time. But one other thing I do want to bring up with palliative care too is I think there's a big misperception, especially also amongst physicians, that it only refers to a physician. And what palliative care is, it's this whole interdisciplinary team. So it's not only just a palliative care, like a fellowship trained physician, it's their ACPs, it's their nursing, it's their social work. They have physical, like like physical therapy in like a different section also as part of hospice. But one other avenue that we don't really know about, or like that's not often discussed, is like child life referrals, for example. So especially if you have patients with cancer with really young children under 18, it's a difficult thing for them to cope. And often a lot of patients will tell me, I don't know how to tell my kid that I have cancer. And like this is another great way to help support you through your treatment. So it's like one less thing you can take off of one thing you can take off of your plate, essentially. So, I mean, I think in general, you should always have palliative care on board, but of course, like resources are limited. So it's whatever you can get to do.
And I have similar feelings, also strong feelings coming from the advocacy world and the whole person care model. In my mind, palliative care, it is supportive care and it should be standard of care. And it's something that we need to continue to argue for from the get-go. But to the point of balance, right? Patients are dealing with so much, especially in this rare cancer space with the uncertainties and understanding their diagnosis and just their initial treatment pathway. So really finding the balance of when you introduce some of that supportive care. But I do think that it's integral and it should be standard of care. And I also want to highlight that there's working groups out there that are really trying to advocate for this. So we're actually, CSC is part of a coalition called Together for Supportive Cancer Care, working to find equitable supportive care across the cancer timeline. So there are groups out there that are really fighting for this. And I think that it should be fought for.
I honestly think we all have strong feelings because we've all in different ways seen how beneficial it can be. I mean, the benefits of having, and I love the point that it's a team. It's not, you know, this is a whole other conversation, but I think a lot of people think of, treatment teams being the physician, and it couldn't be further from the truth. That it really is a team of people that are all supporting, including out into the advocacy networks. And there's all these resources and all these people that are there to help. And if you don't take advantage of those, or if you're kind of walled off to that, it can be at a detriment. So I think maybe we could pause. I don't know, Kira, do we have any other questions?
No, nothing right now.
Okay. Maybe we can see if anyone participating has any other questions. Then I think we can kind of wrap up with thinking about where do you see the future of rare cancers going in terms both of treatment, and it's such a broad question, but I think so many things are changing. I don't think 15 years ago we would have thought about T-cell engaging therapy, or how we treat plasma cell dyscrasias and how we treat melanoma being at all the same, other than like we gave chemotherapy that didn't work. And now there's so many overlapping things that I honestly think there's a lot of hope that rare cancers are going to get more treatment options in the future, given the fact that we can do more tissue agnostic trials that are basket trials that include patients with different histologies and doesn't exclude these rare cancers. I think we have to advocate for that. But I'd be curious if any of you think any other thoughts.
So I guess one thing I see with rare, like just the treatment and how it would affect like rare cancers in the future. Like the internet is a lot more power now, right? So the patients that come to you are much more empowered than they would have had been 20 or 30 years ago, because there's much more access to information. So, and unfortunately, the flip side of that too is a lot of onus is also put on patients in those situations. So it's definitely a good balance. But I think in general, knowledge is power. But the other part of this too is because we have this space, it would increase access to more clinical trials, more research, more things like that we can get for these patients too. And it would facilitate a lot more communication in the future. And as like treatments change, we see increases in all types of cancer or like across the globe, right? So things that might have been rare cancers a few years ago, we are starting to see much more frequently now, and we might actually have more options for for treatments too, because of just an increase in incidence.
Yeah, I'd love to build on that. And I think in general, the pathway for most cancers in the future is a little bit of what we've already touched on with the treatments and precision medicine, right? And understanding that treatments are becoming more and more specific to the individual and their specific mutations or the changes in their cancers. So I do think that's the direction that MDS is heading, as well as many other cancers. But to build on the point about awareness, right, and the information that's out in the world, I think that's also an important piece to hold on to when it comes to advocacy and to communication, and understanding that even though these conditions are quote unquote rare, right? As I said earlier, it's about 10 to 15,000 people in the US who will be diagnosed with MDS in a year. That's thousands of people, thousands of people still who have MDS. And there are people out there like us and other organizations that are working to better understand it and to better help patients, survivors, and caregivers. So I want to do sort of one last plug for what we do in advocacy, and just helping people understand that we're out there, that we really want to arm you with knowledge first and foremost, right? We want to help guide your conversations with your providers, and we want to provide you any type of free support and care that we can, regardless of what that looks like. So at CSC, again, thinking about how we give you information, we have a whole series called Frankly Speaking About Cancer. These are developed specifically for different cancer types, including rare cancers like MDS. This will help you understand the basics of the rare cancer, what you should really know, and then how to talk about it with your doctor, right? That's one of the most important parts in understanding and navigating a cancer diagnosis is, how do I talk about this with my doctor? And as we see these constant changes, right, in diagnosis and treatment, knowing that we're trying to stay on top of those things for you so that you know the right questions to ask along the way. And then again, just leaning into the free support we have. We have a free toll-free helpline. We have 196 locations, as I mentioned earlier, where you can get free care and support. So I think as the cancer landscape continues to change as a whole, and as MDS changes, just know that there are people out there who are trying to stay on top of those changes for you.
Yeah, I would just add to that very quickly, because we do have a couple of questions. Information is very empowering for patients, but there is a vast amount of misinformation that is floating around as well. And oftentimes the scariest thing about misinformation is that it's kind of, it's built on things that have some level of truth, but largely are false or unverified. And I think keeping in mind the source of your information, whether or not it's other patients who are being treated, or an advocacy group, or physicians, or reliable sources, is super important, because it's very nerve-wracking to have cancer. It's incredibly nerve-wracking to have a rare cancer. You're in that time, I think there's so much to explore, every possible option, but there are, unfortunately, a lot of avenues of just misinformation that we have to be really, really mindful of. So 2 questions. One, could we touch on the experiences with treating rare diseases during fellowship, if there's time? And also, are multi-cancer genetics screening tools impacting the diagnosis and treatment of rare cancers, or do you see a role for these in the future? So maybe I could defer the first question to Risha and Arthur. I can just touch briefly on the second one. Absolutely. I think, as I was touching on before, the better delineation of genetic mutations that are common in multiple cancers, or now thinking about antibody drug conjugates and different IHC markers, which are proteins on the surface of the cells that could be used as targeted chemotherapy or T-cell engagers, things like that. I think honestly this is where we're going, and hopefully in that way we'll develop a lot of new therapies that were previously not possible by doing a single trial in one specific type of tumor. I think there's a lot of issues with basket trials too, but we can leave that for another day. How about rare diseases and fellowship? Any experiences with those?
So I can touch base on a little bit. So in terms of pancreatic neuroendocrine tumors, so I think going back to how like the different spectrum of it is, when I was in clinic, we see patients with pancreatic neuroendocrine tumors on like octreotide, which is basically a hormonal treatment, and their disease has been stable. They're doing fine. Whereas like in the hospital, I've seen patients where like the disease is so aggressive, we would be starting chemotherapy, like inpatient. So I think, again, like because it's so rare, one of the things I think it's most important is being aware that this is something that exists even within the pancreatic cancer. And sometimes, like with imaging, we see these like lesions in the pancreas, etc. And then the questions become to us oncologists is what do we do about it? There was usually, right, like I would advocate for if it's like consistent with their goals, etc., like to try to find a diagnosis because 1 to 2%, it could be neuroendocrine, the treatment is completely different than and the prognosis is very different compared to what we see with like the typical pancreatic adenocarcinoma. So that has been my experience. And then I think targeted treatments, I'm really excited for, especially like as we, expand access to care and also access to these treatments, makes it more accessible to patients as well, rather than like having treatments being like all like localized to a specialized cancer center. These treatments will hopefully be able to like extend our reach to patients in the community as well.
I guess on both of those questions, in terms of the screening tools, I really do see it taking off a lot in terms of opening up treatment options for patients with rare cancers, because there might be more targeted therapies where drugs are now just will like start to be universally approved for a certain genetic mutation that's expressed in the cancer. For diagnosis in a patient that has no symptoms, I think that I would probably see it taking a lot longer for us to get to that level because we would just need more information. And then in terms of just experiences during fellowship with rare diseases, I think there's a couple of things, right? There's for physicians, you see and you learn by seeing a patient, taking care of a patient. But in oncology, there's also other avenues to learn these cases. So during my training, I really wanted to specialize in blood cancer. So I, compared to some of my co-fellows, probably saw a lot more of PCL and MDS because that's what I was focusing on. But these other rare conditions like neuroendocrine tumors, for example, are also presented on cases like tumor boards that trainees and other attendings attend. And you can get a lot from learning by hearing how other oncologists manage something and the discussions too, because that will help build up like more options and more ways to approach a case that even if you've only seen a couple, you've heard so many more experiences and you've spent more time looking at literature and what other oncologists are also seeing. So that also helps increase your own knowledge and to help you do a better job taking care of patients that have these rare diseases too.
And I can't speak to the fellowship question, but I'll quickly make a comment about the multi-cancer, especially early detection when it comes to the patient lens and support, right? So thinking about what that looks like to have early detection in that space and understanding that what that means for a patient, right? To go through that, what it means from an access and health equity lens as well. So if you tell an individual that there's something detected, now what? And right now, a lot of people don't know now what, or they don't have the support and the logistics to follow through with the now what. So I think it's important to keep in mind that these amazing advances, and they are amazing, in helping us to early detect certain types of cancers and conditions, we need to understand it's just the first part of the advancement that we need to consider, and that all of the logistics that follow are just as important.
No, well said. I would just finish with with rare cancers, especially given the the siloing of experience with these cancers, probably the larger academic centers. It would always be a good idea, I think, to consider clinical trials. It's oftentimes even earlier phase clinical trials now have come so far in terms of what we can offer. And I'm obviously biased. This is the space I work in, but whereas 25 years ago we were just trying different chemotherapies that didn't necessarily provide a ton of benefit, as we found out. We now have so many more new therapies that are incredibly promising, but they're still in the trial phase development, with more and more targets and therapies, going into clinical development every month. So at least exploring those options, whether or not it's when you're first diagnosed, or whether or not it's after a treatment unfortunately not working the way we would hope it would, definitely something to keep in mind. Well, I think this has been a wonderful conversation on such an important day. Does anyone else have any last thoughts or comments?
One thing I just want to add off of what Matt was saying too, is I think at academic centers, the physicians you see do see high volumes of certain cancers compared to community oncologists. So getting a second opinion or an opinion at those centers is really great, but it is also a lot of burden for patients to make that commute. So another option to save some of that is some of these treatments can be done locally at your own like at a place that's close to you. So a lot of our patients that we see sometimes that are here for a rare cancer might have two oncologists. There's one that they're seeing regularly to manage their chemotherapy. And when there's scans or something new that comes up, they follow up with the specialist in that specific area, just so they don't have to travel every 2 weeks for treatment. But like at the same time, doing this would also help give them access to clinical trials too, if they wanted one in the future.
Yeah, and I think the last thing I would say about clinical trials is that what we have found in our work is that one of the greatest obstacles for people pursuing them is knowing they exist, which sounds strange, but it's true. And so what we do on our end as advocacies, or an advocacy organization, we try to encourage patients to ask their doctor, right? What is out there for me in the clinical trial space? So I think that's important to note, that one of the biggest obstacles is just talking about them.
No, absolutely. Yeah. I mean, oftentimes the earlier, kind of like palliative medicine, the earlier it's involved in your care, the earlier you talk about clinical trials, the more you familiar are. And there's, unfortunately, just with clinical trials, as with anything else, there's so much misconception and misinformation. I mean, almost every single patient I meet to discuss a trial wants to ensure they're not going to get a placebo, which is just not something we do. That's not, particularly in early phase trials, there's no placebo arm. So kind of dispelling that at every level is super important. Well, great. I think with that, we can wrap up. It was an excellent conversation, and I think such an important topic to touch on.
Yes, thank you so much, everybody, for such a thoughtful and informative discussion today. It's so wonderful to hear about all this progress being made in these rare diseases and the work being done to advance patient-centered care. So thank you to the audience for tuning in today as well. Be sure to subscribe to the YouTube channel to check out all the other videos and panels we have, and I hope that you all have a great rest of the day.
All right, thank you.
Thank you.
Take care.